Okay, at the outset, I express my sincere gratitude to the state leaders, state academic cell, Kozhikode district office bearers, and Dr. Jinesh, the dynamic Kozhikode academic cell convener, for giving me this opportunity. As you know, actually, this topic is not an ideal one to discuss in a Zoom platform. Definitely, we will miss the mutual interactions that was really needed for a topic like ECG. And the aim of this presentation, sorry, Tekaya. സ്ലൈഡ് നീങ്ങുന്നില്ലല്ലോ സ്ലൈഡ് നീങ്ങുന്നു
എന്തുപറ്റി ജമീൽ? സ്ലൈഡ് മൂവ് ചെയ്യാത്തതാ ജമീൽ സാർ?
The aim of this presentation is don't get panic when you get an ECG. നമുക്കറിയാം പലപ്പോഴും നമ്മൾ ECG കിട്ടുന്ന സമയത്ത് നേരത്തെ മുരളീധരൻ സാർ പറഞ്ഞ പോലെ പലപ്പോഴും നമുക്ക് കൺഫ്യൂഷൻ ആണ്. ആ കൺഫ്യൂഷൻ ഒഴിവാക്കാൻ വേണ്ടിയിട്ട് ഏറ്റവും ബേസിക് ആയ കാര്യങ്ങൾ ആണ് ഇന്നത്തെ ഒരു പ്രസന്റേഷനിൽ ഞാൻ പറയാൻ ഉദ്ദേശിക്കുന്നത്. സോ ഹിയർ ഐ എം കവറിംഗ് ഓൾ ദ mainly the basic aspect of ECGs, not dealing with the detailed electrophysiological and the pathophysiological aspect manifestation of ECG. So just relax and just covering the only the major points of the ECG. Sorry.
ഇപ്പൊ ശരിയായിട്ടോ?
അല്ല, അത് ചെയ്യുന്നില്ല. മാറുന്നില്ല, എത്താൻ നോക്കണം.
സർ ഓഡിയോ ഇല്ലാത്തതുപോലെ.
ഇതിങ്ങനെ വരുന്നുള്ളൂ, എന്തോ ഒരു പ്രശ്നം ഉണ്ടായില്ലേ? അതും പറ്റുന്നില്ലല്ലോ, നീങ്ങുന്നില്ല, അതാണ്. Each event has a distinctive waveform, the study that we will see in the subsequent slides, and the study of waveform can lead to greater insight into patient's cardiac pathophysiology.
ജിനീഷിന് ഷെയർ ചെയ്യാൻ പറ്റുമോ? സ്ലൈഡ് ജിനീഷിന് നോക്കിയോ? അങ്ങനെ നോക്കിയോ?
അങ്ങനെ ചെയ്യാൻ ഒരു ഓപ്ഷൻ കാണുന്നില്ലല്ലോ മാഡം, നമുക്ക് കമ്പ്യൂട്ടറിൽ ഇല്ലല്ലോ സാധനം.
അല്ല, ജിനീഷിന് അയച്ചു കൊടുത്താല് വാട്സപ്പിൽ എങ്ങനെ അയച്ചു കൊടുത്താല് ജിനീഷ് ഡോക്ടർ ഷെയർ ചെയ്യാൻ പറ്റുമെന്ന് തോന്നുന്നു.
വാട്സാപ്പ് നോക്കിയാലോ?
ഓക്കെ സാർ ഒന്ന് അയച്ചെന്നു.
അല്ല, വാട്സാപ്പ് നോക്കിയാൽ ചെയ്യാൻ പറ്റുമോ? കേട്ടെ, ഹലോ, വാട്സാപ്പില് two, three AVL and AVR and IVF, that is considered as an augmented lymph node, unipolar and bipolar lymph nodes. Actually, ഈ ലീഡ് എന്ന് പറയുന്നത് ഹൃദയത്തിന്റെ ഹാർട്ടിന്റെ ഒരു വ്യൂല്, നമ്മളൊരു ഒരു ഹാർട്ടിനെ ഏത് വ്യൂ ആണ് നോക്കുന്നത്, ഏത് സർഫസ് ആണ്, ഏത് വാൾ ആണ് എന്ന് റെപ്രസെന്റ് ചെയ്യാൻ ആക്ച്വലി ലീഡ്സ് കൊണ്ട് ഉദ്ദേശിക്കുന്നത്. സോ ദാറ്റ് ചെസ്റ്റ് ലീഡ്സ് V1 to V6 look at the heart on the transverse plane, V1 and V2 look at the anterior of the heart and the ventricle, and the V3 and V4 anterior and septal, V5 and V6 lateral and the left ventricle. And the limb leads, we have bipolar limb leads and unipolar limb leads, and AVL and 1, 2 and lead 1 and 2 represents the lateral wall of the heart, 2, 3 AVF represent the inferior wall of the heart, and AVR represent the right side of the heart. And the limb leads are placed in the right arm, left arm, and left leg, and the electrodes are attached to the skin surface. These are all some basic aspects. Then the electrode placement. For the chest electrodes, we know we have V1 to V6, and V1 is placed at the 4th intercostal space in the right sternal edge, and the V2 4th intercostal space at the left sternal edge, V4 over the apex, that is in the 5th intercostal space midclavicular line, V3 halfway between the V2 and V4, V5 at the same level as V4 but on the anterior axillary line, V6 at the same level as V4 and V5 but on the mid-axillary line. This is some special situation. For example, RVMA special lead V3R and V4R corresponding left side V3 V4R and corresponding right side lead which ECG അത് V3R and V4R എന്ന് നമ്മൾ പറയുന്നത്. Okay, so interpreting the ECG. So ഒരു പേഷ്യന്റിന്റെ എല്ലാ കാര്യങ്ങളും, ബേസിക് ആയിട്ടുള്ള എല്ലാ കാര്യങ്ങളും വളരെ പ്രധാനപ്പെട്ടാണ് ഒരു ECG ഇന്റർപ്രറ്റ് ചെയ്യുമ്പോൾ. ദാറ്റ് ഇൻക്ലൂഡ് ദ നെയിം, ഡേറ്റ് ഓഫ് ബർത്ത്, ഏജ്, ടൈം, ഡേറ്റ്, എവറിത്തിങ് ഈസ് ഇമ്പോർട്ടന്റ്. ബിക്കോസ് തിരക്കുള്ള ഒരു കാഷ്വാലിറ്റിയിൽ ഒരേ പേരുള്ള രണ്ട് പേര് വന്നു കഴിഞ്ഞാൽ ECG മാറിപ്പോകാനുള്ള ഒരുപാട് സാധ്യത ഉണ്ട്. ഈവൻ ഏജ്, ഒരു 70 വയസ്സുള്ള 2 ഗോപാലന്മാർ ഒരേ സമയം കാഷ്വാലിറ്റിയിൽ ഇരിക്കുകയാണെങ്കിൽ നമുക്ക് ECG മാറിപ്പോകാൻ അങ്ങനത്തെ സന്ദർഭങ്ങൾ ഉണ്ടായിട്ടുണ്ട്. So everything is important. So you should record the you should note the time date of the ECG, and you should know the indication of ECG, whether it is for chest pain or for as a part of the routine pre-op evaluation. ചില സന്ദർഭത്തിൽ നമ്മൾ സീരിയൽ ECG എടുക്കാറുണ്ട്. In that case, you have to number the ECG as 1, 2, or 1, 2, 3, etc. Then after this basic preliminary assessment of the patient, then you have to read the ECG in a sequential order that include the calibration, rate, rhythm, axis, and elements of the tracing in each state that we will see later. Okay, before going to the ECG reading, let us see what is an ECG paper. ECG paper kand familiar aayittulla. So what is an ECG paper? Nammal ECG paper is small square and large square okke kandittunde. Actually, this electrocardiographic paper is a graph paper with horizontal and vertical lines at 1 millimeter distance that intersect to form large and small squares. Horizontal measurement indicate the unit of time, and vertical line reflects the voltage. താഴെ കാണുന്ന സെക്കൻഡ്സും മേലെ വോൾട്ടേജ് ആണെന്നാണ് പറയുന്നത്. അതായത് ഒരു സ്മോൾ സ്ക്വയർ, ഈ സ്മോൾ സ്ക്വയർ റെപ്രസെന്റ് 0.04 സെക്കൻഡ്. സോ 5 സ്മോൾ സ്ക്വയർ റെപ്രസെന്റ് 0.2 സെക്കൻഡ്. ഇത് വളരെ ഇമ്പോർട്ടന്റ് ആണ്. ഇനി അങ്ങോട്ടുള്ള ECG റീഡിംഗിൽ ഇത് വളരെ നമുക്ക് ഇടയ്ക്കിടെ ആവശ്യം വരുന്ന ഒരു കാര്യമാണ്. ആൻഡ് ഈച്ച് സ്മോൾ സ്ക്വയർ അറ്റ് ദ vertical line represent 0.1 millivolt. 5 small square represent 0.5 millimvolt. താഴെ 0.1 millimvolt, മേലോട്ട് 5 സ്ക്വയർ വരുമ്പോൾ അത് 0.5 millimvolt. Horizontal line വരുമ്പോൾ again I repeat 0.04 second for each small square, and 5 square, that means 0.04 into 5, that is 2.2 second. സാധാരണ millisecond പറയാം, but 200 millisecond എന്ന് നമുക്ക് പറയാം. Okay, that's about the ECG paper. വളരെ പ്രധാനപ്പെട്ടാണ്. നമുക്ക് റേറ്റ്, റിതം എല്ലാം കാൽക്കുലേറ്റ് ചെയ്ത് നോക്കുന്ന സമയത്ത് ECG പേപ്പറിന്റെ എക്സാക്ട് ക്യാരക്ടറിസ്റ്റിക് you should know about these basic things. Okay, then every 5 square represent 1 second. കാരണം നമുക്കറിയാം ഒരു സ്ക്വയർ ഒരു ലാർജ് സ്ക്വയർ എന്ന് പറയുന്നത് 0.2 സെക്കൻഡ് ആയി. അപ്പോ 5 സ്ക്വയർ ചേരുമ്പോൾ അതൊരു 1 സെക്കൻഡ് ആയിട്ട് മാറും. Okay. Then you have to see the standardization of the ECG. So what is the importance of standardization? Why are taking standardization? Standardization is very important. നമുക്ക് ഏത് ECG എടുത്ത് നോക്കിക്കഴിഞ്ഞാൽ നമുക്ക് കാണാൻ സാധിക്കും ഒരു ECGയുടെ എക്സ്ട്രീം എൻഡിൽ ഒരു റെക്ടാങ്കുലർ ഷേപ്പിലായിട്ടുള്ള ഒരു ബോക്സ് പോലത്തെ കാര്യം കാണാം. That indicates the standardization. Standardization or calibration is used to adjust the voltage or height of the QRS complex in order to makes the interpretation easier. കാരണം ഇത് കാലിബ്രേഷൻ കറക്റ്റ് അല്ലെങ്കിൽ നമ്മൾ ECG കറക്റ്റ് ആയിട്ട് നമുക്ക് ഇന്റർപ്രറ്റ് ചെയ്യാൻ സാധിക്കില്ല. The usual calibration is 10 millimeter, that equal to 1 millivolt. എപ്പോഴും ECG എടുത്ത് നോക്കുമ്പോൾ ആ കാലിബ്രേഷൻ ആണോ കറക്റ്റ് ആണോ എന്നുള്ളതാണ് ആദ്യം നമ്മൾ നോക്കേണ്ടത്. Another important factor about the ECG is paper speed. Paper speed is 25 meter per second. That's also important. കാരണം 25 മീറ്ററിൽ കൂടിയോ കുറഞ്ഞു കഴിഞ്ഞാൽ അത് ECG നമുക്ക് ആക്ച്വലി ബ്രാഡികാർഡിയോ ടാക്കികാർഡിയായിട്ട് റിഫ്ലക്ട് ചെയ്യാൻ ചാൻസ് ഉണ്ട്. യഥാർത്ഥത്തിൽ പേഷ്യന്റിന്റെ ടാക്കിയോ ബ്രാഡിയോ ഉണ്ടാവില്ല. പക്ഷേ if the paper speed exceeds or exceeds 25 meter per second, so we won't get the correct exact rate of the patient. So the paper speed is 25 meter per second. Then coming to the electrophysiology of the heart, that is very important. Back to our physiology class, we have studied, we have an SI, we have pacemaker like SI node, AV node, etc. So SI node is the intrinsic natural pacemaker of the heart located in the upper part of the right atrium. Usually the electrical activity generated in the SI node and spread through the conduction pathway, atria, then to AV node, bundle of these and these branches like left bundle branch and the right bundle branch, the Purkinje system, and ultimately to the ventricles, reaching resulting in electrocardiographic complex consisting of PQRST during 1 beat of the heart. So ഒരു ഹാർട്ട് ബീറ്റിന്റെ ഒരു കാർഡിയക് സൈക്കിളിനിടയിൽ ഇത്ര ഇവന്റ് നടക്കുന്നുണ്ട്. സ്റ്റാർട്ടിംഗ് ഫ്രം ദ SI node to the ventricular cells, SI node to again SI node to AV node, then to AV bundle branches and Purkinje cells fibers, then to the ventricular system. So ventricular fibers. This is a nutshell about the conducting system of the heart. There are disturbances occur in the conducting system heart, resulting in the various ECG manifestations that we will see. The elements of the trace, you all know the elements of the trace of the elements of the ECG include there's a P wave followed by a PR interval, then a QRS complex followed by a QT wave. Sometimes you may get U wave also. So this is called a PQRST complex of the ECG. So what is this P wave? P wave is the atrial depolarization. Atrial contract change P wave. So P wave is the atrial depolarization. Then QRS, what is QRS? QRS is the ventricular depolarization. After ventricular depolarization, after a few then the T wave occur. T wave is the atrial repolarization. So PQRST means atrial depolarization, then ventricular depolarization, then atrial repolarization. These occur in the one cardiac cycle or during one heartbeat. Okay, this is a normal ECG. Share ECG കാണുന്നുണ്ടോന്ന് അറിയില്ല. കമ്പ്യൂട്ടർ സ്ക്രീൻ ഉള്ളവർക്ക് കമ്പ്യൂട്ടറിൽ ലാപ്ടോപ്പിലാണെങ്കിൽ കുറച്ചുകൂടി എളുപ്പമായിട്ട് കാണും. ഫോണിൽ കാണുന്നവർ സ്ക്രീൻ എൻലാർജ് ചെയ്ത് കഴിഞ്ഞാൽ you can see very well the normal ECGs. Okay, this is the normal ECGs. What are things you are expecting in a normal ECG? In a normal ECG, it should be in the sinus rhythm. So what is mean by a sinus rhythm? Sinus rhythm, there should be a P wave before the QRS complex. So there should be a P wave before the QRS complex and the rate between 50 to 100 and axis plus 90 or minus 90 and intervals PRS 0.1 to 0.2 second or QRS less than 0.12 to 1.12 second or 120 milliseconds. And the limb leads you can see AVR lead and augmented lead. AVR is negative. AVR is always negative. Lead change dextrocardial limb leads should be always negative and the lead will always positive if it is normal. And there will be R wave progression. R wave V1 to V6 there will be an R wave progression. R wave progression infarction ischemia we can see there won't be any R wave progression. So small to tall R wave we can see from V1 to at least up to V5. That is a normal characteristic, the characteristic of a normal ECG. So this is again with all these features, you can see a normal 12 lead ECG with the rate normal, axis normal, and PR interval, P normal, everything is normal. Okay. Then coming to the basics. So when you get an ECG, first you have to read the ECG in a very sequential way in ordered manner. First you see the rate, heart rate. How will you calculate the rate? Heart rate calculate so heart rate is, if the heart rate is regular, how will you calculate? MBBS count the number of large square between the R waves. So that divided the rate is equal to 300 divided by the number of the large square in between the two R waves. Suppose that there is a 4 large square between the two R wave. So R 300 by 4. So that means 75 beats per minute. As per this, if there is 4 large square between two R wave, so 75, 5 square heart rate is 60 per minute. So this is applicable only to a regular rhythm. Only if it is a regular sinus rhythm with a regular ആണെങ്കിൽ മാത്രമേ ഉള്ളൂ ഈ ഒരു ബോക്സ് മെത്തേഡ് നമുക്ക് കാൽക്കുലേറ്റ് ചെയ്യാൻ പറ്റുള്ളൂ. ഈ ഒരു എക്സാമ്പിൾ ഈ ഒരു ECG വഴി നമുക്ക് കാണാൻ സാധിക്കും. ഓക്കെ, ആരോ കാണുന്നുണ്ടോ? അല്ലെങ്കിൽ റെസ്പോണ്ട് ചെയ്യോ? ആരോ കാണുന്നുണ്ടോ? ഹലോ? Okay. Here this is, you can see the 2 RR interval. Here you can see the 5 square, 1, 2, 3, 4, 5. So 300 by 5, that is 60 per minute. Suppose the rate is irregular. How will you calculate the rate? Okay, if we method and adopt you take 6 seconds of an ECG. 6 seconds each small square represent 0.04 second, large square 0.2 second. 5 square 1 second time. 6 second means 30 square. 30 large square that indicates 6 seconds. 6 seconds QRS complex. Okay, for example, the diagrammatic representation, there is 8 QRS complex or R wave in a regular ECG. So that is multiplied by 10. So you will get 80 per minute. This is the way you calculate heart rate of an ECG with irregular rhythm. Okay, I think you got the point. So then you follow other things, that is, you have to ask the questions in yourself when you get an ECG. Are there any abnormalities in the P wave? What is the cardiac axis? Is the QRS complex of normal duration? Are there any abnormalities in the QRS complex? Any abnormal Q wave? Is the ST segment raised or depressed, or is the T wave normal? ഇതെല്ലാം നമ്മൾ ഓരോന്നായിട്ട് നോക്കുന്നു. Rhythm was already mentioned, sinus rhythm. That is the definition. As per the definition, cardiac impulse originate from the sinus node. That is a sinus rhythm. So there should be every QRS must be preceded by a P wave. Okay. So what are the elements of the tracing we are seeing? We are looking in ECG. In the P wave, we have to look the magnitude and shape. In the PR interval, we have to see the whether it is prolonged or normal, because normal PR interval is 3 to 5 small square. 5 small square, 0.2 second or 200 millisecond. Then pathological QRS can be pathological or non-pathological. Then QRS complex, you have to see the magnitude, duration, and the shape of the QRS complex. And ST segment should be isoelectric, and T wave, the magnitude and direction. Then sometimes you have to see the QT interval or QTC interval. That is a formula by QT by root of RR interval. Okay. Then coming to the each wave of the ECG complex. P wave. First one, P wave. P wave. What is P wave? P wave is due to atrial depolarization. So usually in a normal P wave, there should be 2 to 2.5 small squares, and in length, and 3 small square, maximum 3 small square width. That's a normal shape of a P wave. So it can be abnormal. Suppose if there is a right atrial enlargement, you can see a tall P wave, tall pointed P waves more than 2.5 millimeter. That is called P pulmonale. Or sometimes you can get notched bifid or M-shaped P wave in limits that you can get in left atrial enlargement, classically seen in the ECG of a mitral stenosis. Why there is notched or M-shaped P wave occur in mitral stenosis? Actually, this P wave is due to the summation of the right atrial systole and the left atrial systole. The difference is P wave. But in mitral stenosis, what happened? Because of the stenosis of the mitral valve, the left atrial depolarization occurs somewhat lately than the right atrial depolarization. So, we see notched P wave in the right atrial followed by left atrial. That's this shape. Here I have shown there's a wide notched P wave of the mitral stenosis. So this is a P wave of pulmonary corpulmonale. P wave example, corpulmonale can occur upright tall P wave and notched P wave in the left atrial enlargement, classically seen in the mitral stenosis. Then coming to the PR interval. So what is PR interval? So after the PV, we have to look at the PR interval. PR interval is measured between the start of the P wave to the start of the QRS complex. There are some conditions in which PR interval is prolonged, and there are some conditions in which PR interval is shortened. I'll give a classic example. There is a 40-year-old with a chest pain and palpitation. So you can see in this ECG, if you carefully look at the ECG, you can see a very short PR interval and a slurred upward appearance at the beginning of the QRS. That is called delta wave. This is called a WPW syndrome. Due to the accessory pathway, it's a pathway of Kent. Then details of pathophysiology because of the lack of time. Already we are late. So this is a classical example of a patient with very short PR interval and PW syndrome due to accessory pathway. Okay. Then coming to the next component of the QRS, the ECG, PQRST, QRS is due to ventricular depolarization. So what is Q wave? Q wave is initial downward deflection after the P wave. R wave, initial upward deflection after the Q wave. Sometimes you may not get the Q wave. If Q wave is absent, R wave follows P wave after the PR interval. Then S wave is a negative deflection following the R wave. Then axis, normal QRS axis is from the -90 to +90 degree, -30 to -90 degrees referred to as the left axis deviation, and +90 to +180 degrees referred to as the right axis deviation. So axis calculate different methods. Usually we endowment triangle easy to calculate. But Zoom platform, so I will give a easy method. I will tell. That is, you take the lead 1, lead 2, and lead 3. Every positive every upward deflection is taken as a positive. And melotilla lead one in a melotan arangil, the positive, negative. Turning negative angle. If it is positive in lead 1, lead through, lead 2, and lead 3, that is normal axis. Suppose you see this ECG. Here you can see the lead 1 is positive. That means there is a positive deflection in the lead 1, and lead 2 there is negative, and lead 3 there is negative. So it's simple. This is the left axis deviation. Calculate. That is a left axis deviation. In right axis deviation, there will be lead 1 will be negative and lead 3 will be positive. That is the right axis deviation. So clinical bedside ECG axis calculate easiest measure. So again, AVF again, if it is both positive, normal axis, and lead 1 positive or lead AVF negative, that is possibly left axis deviation, lead 1 negative and lead AVF positive, that is a right axis deviation, both negative, extreme axis deviation. Then coming to the Q wave. Q wave is very important as far as an ECG is concerned. Most of the time it indicates an necrosed or infarcted area, an old lesion. Pala karyangalum assess cheyan pattuna Q wave importance. Can be pathological or non-pathological, because normal Q waves can occur in lead 1, 2, 3 AVL or V5 or V6. When we say a lead Q wave is pathological, പലർക്കും സംശയമാണ്. പല പേഷ്യൻസും നമുക്ക് റെഫർ ചെയ്യാലോ അല്ലെങ്കിൽ പലരും കൺസൾട്ടേഷൻ Q wave കണ്ടിട്ട് കൺസൾട്ടേഷൻ കാണാറുണ്ട്. Actually, Q wave can be pathological if it is deeper than 2 small squares. That is 0.2 millimolar കൂടുതൽ അത് ഡീപ്പ് ആണെങ്കിൽ ആണ് അത് pathological ആയിട്ട് നമ്മൾ കൺസിഡർ ചെയ്യാം, or wider than 1 small square. Then only it will be considered as a pathological Q wave. Then the QRS, the width of in the QRS, we will see the width and height of the QRS. Usually the width of the QRS is less than 0.12 seconds or 120 milliseconds. That means 3 small square. So wider QRS complex is classical of a ventricular conduction problem that occur in the right bundle branch block or the left bundle branch block. Now, there will be in the height of the V wave, there will be V1, there will be S wave is predominant than the R wave, then followed by then from V1 to V6, that the progression of the R wave. V5 or V6, usually R wave can be up to 25 millimeter. So height of the QRS is important when you want to know about the ventricular hypertrophy by ECG. നമുക്കറിയാം ക്രോണിക് ഹൈപ്പർടെൻഷനിൽ ഒരു വെൻട്രിക്കുലർ ഹൈപ്പർട്രോഫി വരാം. നമുക്കൊരു കാഷ്വാലിറ്റിയിൽ ഒരു പേഷ്യന്റ് പെട്ടെന്ന് ഒരു BP ആയിട്ട് വന്നു കഴിഞ്ഞാൽ ഒരു BP 200/100 or 220/100 ആണെങ്കിൽ ഈ BP ഇപ്പൊ വന്ന BP ആണോ മുമ്പ് വന്നുള്ള BP ആണോ നമുക്ക് അറിയണമെങ്കിൽ ഏറ്റവും എളുപ്പമുള്ള മെത്തേഡാണ് ECG എടുത്ത് ടാർജറ്റ് ഓർഗൻ ഡാമേജ് ഉണ്ടോ നോക്കുക എന്നുള്ളത്. ബൈ വെൻട്രിക്കുലർ ലെഫ്റ്റ് വെൻട്രിക്കുലർ ഹൈപ്പർട്രോഫി ഉണ്ടെങ്കിൽ ദാറ്റ് മീൻസ് പേഷ്യന്റ് ഹാഡ് ക്രോണിക് ഹൈപ്പർടെൻഷൻ, ടാർജറ്റ് ഓർഗൻ ഡാമേജ് ഉണ്ടായെന്ന് അർത്ഥം. സോ വൈ ദർ ഈസ് വെൻട്രിക്കുലർ ഹൈപ്പർട്രോഫി, why there is height of the QRS increase in the ventricular hypertrophy? Because an increase in the muscle mass in either ventricle will lead to the increased electrical activity, that leading to increase in the height of the QRS complex. There are many methods to calculate the ventricular hypertrophy. Here also again I am giving the most easiest method of calculating the ventricular hypertrophy, that is by the Sokolow-Lyon criteria. എല്ലാവർക്കും അറിയുന്ന കാര്യമായിരിക്കും എങ്കിൽ തന്നെ ഞാൻ മെൻഷൻ ചെയ്യാണ്. You take the S wave in V1, you take the R wave in V5 or V6. You calculate the number of large in height നോക്കുക. Each square 5 ആണ് നമുക്കറിയാം അല്ലേ, 530. അപ്പൊ R വേവും V5 ആറും V1 or V2 or V6 or V5 R വേവും V1 or V2 R S wave തമ്മിൽ നമ്മൾ കാൽക്കുലേറ്റ് ചെയ്യാം. ഓക്കെ. So if it is more than 35 millimeter, that indicates left ventricular hypertrophy. ഇതല്ലാതെ വേറെ ഒരുപാട് മെത്തേഡ് ഉണ്ട്. ലെഫ്റ്റ് വെൻട്രിക്കുലർ ഹൈപ്പർട്രോഫി, കൊറോണൽ ക്രൈറ്റീരിയ, പിന്നെ AVL വെച്ചിട്ടുള്ള ഒരുപാട് മെത്തേഡ് ഉണ്ട്. പക്ഷെ I think this is the most easiest way of calculating the left ventricular hypertrophy. That is the S in V1 plus R in V5 or V6. If it is more than 35 millimeter, that is left ventricular hypertrophy. This is a diagrammatic picture representation of a right ventricular and the left ventricular hypertrophy. In right ventricular hypertrophy, you will get the upward height of the V1, R height will be increased, and there will be axis deviation also. Then the conduction problem. Interference with the conduction process causes the ECG phenomenon called heart block. We are conduction system. The heart is from the SA node to the internodal pathways, then AV node, AV bundle branches, and like that. So anywhere the interference can occur anywhere in the conduction process can lead to a condition called heart block. Coronary artery disease on heart block is ECG phenomenon called heart block. Suppose the dysfunction occur at the SA node dysfunction like sinus, sick sinus syndrome, sinus arrest, sinus pause can also occur. Suppose the heart block occur at the AV node. It can have 3 types: first degree heart block, or second degree heart block, and the third degree heart block. So what is first degree heart blocks? It's very simple. And simple heart block in the slide. So first degree heart block, there will be prolonged PR interval. Suppose PR interval are important. 0.2 second PR interval, maximum PR interval. That means 5 small square, 5 small square. Okay, 1 large square. So if it is prolonged PR interval, then it is called first degree heart block. So what are the causes of first degree heart block? All PUS associated can occur with acute rheumatic carditis, digitalis, beta blocker, excessive vagal tone, ischemia, and entering the disease in the AV junction or bundle branch system. Okay, here you can see an ECG. Here this is the PR interval. This is the PR interval. Here there is a more than 0.2 seconds. So this is first degree heart block. PR interval is 280 millisecond or 0.28 millisecond. So this is the first degree heart block. And the second degree heart block are 2 types, that is Morbus type 1 or Wengi-Bax phenomenon, or Morbus type 2. So second degree heart block, what happened? Excitation failed to pass through the AV node or the bundle of His. In type 1, there is progressive lengthening of the PR interval, followed by failure of a conduction of an atrial beat, followed by conducted beat with short PR interval, then the cycle repeats. You can see. Okay, this is second degree heart block. There is a progressive prolongation of the PR interval. Here the PR interval prolong. Here PR interval miss. QRS miss. Again, a PR and normal sinus rhythm PQRS, other prolonged PR interval any cycle repeat. This is a Morbus type 1 or Wengi-Bax. And the next one is the Morbus type 2, in which there is a PR interval is constant, but after few normal PQRS complex, 1 beat is dropped in between. That is the Morbus type 2. But in third degree heart block, atrial contraction not followed by the ventricular contraction. That is the third degree heart block. There is no relationship between the P and the QRS. P should be followed by a, so the QRS should be preceded by a P. Then there are no P1 QRS angle very normal sinus, normal rhythm. But P conduct QRS conduct independently. So it is complete heart block or third degree heart block. Then the conduction problems in the right and left bundle branch. Conduction system, the bundle of His left and right bundle branch. And classically, you can see the conduction problems in the right and left bundle branch. See in the right bundle branch block and the left bundle branch block caused by, can occur by infarction or fibrosis. It is most of the time it is associated with the wide QRS, that is the more than 120 milliseconds. That is 3 small square. Okay. So how will you see an RBB in ECG? The RBB കാണാൻ വേണ്ടി ഒരുപാട് മെത്തേഡ് ഉണ്ട്. പക്ഷെ ഏറ്റവും എളുപ്പമുള്ള മെത്തേഡ് നമ്മളെ ടോപ്പിക് ECG മേക്കിംഗ് ECG ഈസി ആണല്ലോ. അതുകൊണ്ട് ഏറ്റവും എളുപ്പമുള്ള മെത്തേഡാണ് ഇവിടെ എല്ലാം പറയുന്നത്. RBBB, you take the V1. യൂഷ്വലി നമുക്ക് V1ൽ ഒരു R വേവ്, ചെറിയൊരു R വേവ് കാണാൻ സാധിക്കും, followed by an S വേവ്. അതാണ് യൂഷ്വലി നമുക്ക് ഒരു V1ൽ കാണാൻ സാധിക്കുക. പക്ഷെ in our right bundle branch block, you can see an extra R after the S wave. So that is the RS R dash pattern. This extra R or R dash. That is the RS R dash pattern with the wide QRS complex. So if you are seeing an ECG with wide QRS complex with the RS R dash pattern in V1, that is indicative of right bundle branch block. This is an ECG with the right bundle branch block. Then the left bundle branch block, again, it's there are different ways to assess the left bundle branch block. Here also you can see, you can adopt an easy way. That is, you take the ECG lead at the V6, where you can see an M pattern in the V6 with the wide QRS. That is the left bundle branch block. Okay, this is a typical ECG of a left bundle branch block. You can see M pattern in the lateral leads, and also there is a wide QRS, that is 0.120 millisecond QRS along with some ST elevation. This is a typical and classical LBBP pattern left bundle branch block. Clinically, left bundle branch block and right bundle branch block on the clinically some difference is there, because right bundle branch block sometimes can occur congenitally or without any significant ischemic or ischemic changes. But left bundle branch block, if it is occurring as a new onset left bundle branch block, at the Mumbai left bundle branch illa the alkana, but chest pain on the patient ear pattern left bundle branch that is actually an indication for even thrombolysis or other intervention. So left bundle branch block you are always consider as significantly. Okay. This is altogether, this is the right bundle branch block. You can see RS R dash pattern in the right bundle branch block and N pattern in the left bundle branch block in the V6 lead. Okay. ECG, Zoom platform physicians in a ECG and the topic may at a peripheral institution ECG, I think. The physician can answer this ECG. This is you can see a right bundle branch block along with the left axis deviation. This is called the bifascicular block. What is bifascicular block? Actually, namakku right bundle branch, left bundle branch undu. Is this left bundle branch has got again divided into two things, that is anterior fascicle and the posterior fascicle. If there is block in the anterior fascicle, then it is called left anterior hemiblock. Left anterior hemiblock, left bundle branch in the block. Adinda kude right bundle branch kodi variyanengil this picture will occur. This indicates extensive damage of the heart that is sometimes can lead to some arrhythmia, and also arrhythmia can develop with this ECG. This is the left bundle branch, this is the right bundle branch block with the left axis deviation is called a bifascicular block. The details I think it's not ideal to discuss these things, fascicular block in this forum. Okay. Then coming to the disorders of the cardiac rhythm, that is very important. At the same, it is also very complicated. At the same, it is very complicated because lot of cardiac rhythm can occur. Lot of cardiac rhythm abnormalities are there. We have seen many clinical cardiac rhythm abnormalities in our clinical practice. And we discuss clinically significant cardiac rhythm discuss. So the cardiac rhythm abnormalities can occur with even the sinus node and also not sinus node. Okay. So what are the sinus rhythm abnormalities? That simply we know that is normal. So we know that there is some phase in respiration, inspiration, some ECG changes occur. R wave varying occur. So QRS and PO come down. This is called sinus wave arrhythmia. There is a change in the ECG pattern with the respiration. Is called a sinus arrhythmia. Okay. There is significant. Then also sinus bradycardia and sinus tachycardia. If it is the rate is more than 100, that is called sinus tachycardia. Both the sinus tachycardia and the sinus bradycardia can occur physiologically and also pathologically. I'm not going to the details of this. Okay. So when the depolarization, so what is an arrhythmia? We have already studied that is where depolarization begins as a node, the heart is said to be in the sinus rhythm. But the heart can capable of depolarization other places also. So depolarization is the sinus node is the control chain. So that is why sinus node is considered the original pacemaker. Subsidiary pacemaker. So suppose the depolarization can begin in other places. The rhythm is named after the part of the heart where the depolarization sequences originates and arrhythmia is said to be present. So in arrhythmia, it can begin in mainly three places, that is the atrial muscles, the region around the AV node or nodal or junctional, or the ventricular muscles. As already mentioned, there are number of abnormal cardiac rhythms. Like escape rhythms, atrial ectopics, atrial tachycardia, atrial flutter, atrial fibrillation, junctional ectopics, junctional tachycardia or a supraventricular tachycardia, ventricular ectopics, ventricular tachycardia, and ventricular fibrillation. Okay, so what is an ectopis? Any part of the heart can depolarize earlier than it should, and the accompanying heartbeat is called extrasystolic, ectopic, or premature contraction. Clinically pulse normal pulse beat miss that is an ectopic. Can be abnormal PV or can be no PV at all, and the QRS may be wide. Abnormal QRS can also occur in the various types of ectopics. This is the classical atrial ectopics and the ventricular ectopics. Different shape of the PV at the different PR intervals in the atrial ectopics. And the PVC, that is a premature ventricular contraction. Here you can see after a normal PQRST complex, followed by there is no PV, wide QRS, and abnormal PV also. So this is the PVC. Now, ECG ഇങ്ങനെ സാധനം കാണുമ്പോൾ ഈ പലപ്പോൾ റെഫറൻസും കൺസൾട്ടേഷൻ കിട്ടാറുണ്ട് PVC. ആക്ച്വലി PVC ഇടയ്ക്കിടയ്ക്ക് ഈ PVC ഉണ്ടാകുന്ന അത്ര കുഴപ്പമുള്ള കാര്യമല്ല. പക്ഷേ if it is occur, number of PVCs increase in a single lead, that we have to consider seriously. Sometimes can lead to a pre-runner of arrhythmia. Multifocal PVC. Okay, this is the PVC. Sometimes tea, caffeine can also induce the PVC. PVC എല്ലാവരും കണ്ടിട്ടുണ്ട്. പലപ്പോൾ ECG നോക്കിക്കഴിഞ്ഞാൽ premature ventricular contraction ഒരുപാട് ECG നമ്മൾ നോർമൽ ആയിട്ട് കാണുന്ന ഒരു സാധനമാണ് ventricular ectopic PVC എന്ന് പറയുന്നത്. Then what is atrial fibrillation? So arrhythmia occurs when individual arterial muscle fibers contract independently, that leading to the asynchronous contraction of the individual atrial muscles. So that means now SA node there will be atrial depolarization. But in atrial fibrillation, there is no effective atrial contraction occur. Only just a fibrillation occur. Adinde sambhavam undavu atrial contraction undavilla, but so the blood flow won't flow normally from the atrium to the ventricle. So there will be lodging of the, there will be formation, chance of the clot formation down. അതുകൊണ്ടാണ് നമ്മൾ atrial fibrillation ചാർജ് സ്കോർ ഒക്കെ വഴി നമ്മൾ anticoagulation ചെയ്യാനുള്ള കാരണം. So that means there is no effective contraction of the atrium, only an asynchronous contraction. Arrhythmia occurs when individual atrial muscle fibers contract independently. So what are the ECG manifestation? There will be definitely tachycardia, then irregular rhythm, no PV, and the irregular QRS complex. So this is a classical ECG of a atrial fibrillation. Anyway, you can see that is the absent PV, characterized by absent PV. RR interval RR interval vary. RR interval RR interval. So all RR intervals are varying seconds. That is the varying RR interval. PQRS in the shape normal ആയിരിക്കാം. പക്ഷേ RR interval varying ആണ്, absent PV, tachycardia. This is the atrial fibrillation with the fast ventricular rate. Atrial fibrillation with slow ventricular rate ഉണ്ട്, വേറെ ചില കണ്ടീഷൻസിൽ വരാറുണ്ട്. Anyway, this is an atrial fibrillation with fast ventricular rate. The treatment ഒക്കെ നമുക്ക് അറിയാമെന്ന് വിചാരിക്കുന്നു. Then the atrial fibrillation. So what is atrial fibrillation? നമ്മൾ പലപ്പോഴും കണ്ടിട്ടുണ്ടാവും atrial fibrillation. So there is a sawtooth appearance. Depolarizes more than 250 per minute. No flat baseline between the PVs. PV in a baseline സാധിക്കില്ല. അപ്പൊ അങ്ങനെ അടുപ്പിച്ച് PV വരും. That is called a appear as a sawtooth. That is a classical sawtooth appearance of a atrial flutter, sawtooth pattern, and atrial fibrillation. Okay, next thing. Then the supraventricular tachycardia, or otherwise called as a junctional nodal tachycardia. So if an area around the AV node depolarizes frequently, SA node and AV node depolarizes frequently, PVs may be seen very close to the QRS complex, or PV may not be seen at all. Adani classical, that is the mechanism of the supraventricular tachycardia. There are different types, mainly AV-NRT and AV-RT. AV-NRT is the most common, and most of the time supraventricular tachycardia, PV is not visible. Sometimes it is there, but it is buried in the QRS complex, and regular QRS complex and narrow complex and narrow QRS. Okay, so that is the supraventricular tachycardia. Here in this ECG, you can see there is no PV and QRS complex narrowed, and there is a tachycardia. That is the supraventricular tachycardia. Okay. Here also it's another ECG with supraventricular tachycardia. That is the normal QRS complex. The RR interval is normal. That is not varying as in ASAF. Absent PV and tachycardia. That is supraventricular tachycardia. This is supraventricular tachycardia. Okay, supraventricular tachycardia different ECG. Okay. Then supraventricular tachycardia and treatment carotid. Initially, you can apply some carotid sinus pressure. The vagal, it sends the vagus nerve, so it can control the rate at sometimes it will really revert back to the normal rhythm. Casualty like SVT sadhana common condition. Before giving any medical treatment, you can apply the carotid sinus. If you see a ECG like this, that is the classical supraventricular tachycardia with the narrow QRS and regular QRS with the absent P wave. Okay, that is the SVT. Carotid sinus message respond in. What is the treatment? You can treat with adenosine. Adenosine the mechanism it's one of the fastest drug, fastest drug acting. At the same time, it will metabolize very fast. So 3-way വിട്ടിട്ട് ചെയ്യണം. ഒരാൾ അഡിനോസിൻ കൊടുക്കണം, ഒരാൾ 3-way കൂടെ നോർമൽ സെലൈൻ പുഷ് ചെയ്യണം. അറ്റ് ദ സെയിം ടൈം ഒരാൾ വേറെ സ്റ്റാഫ് ലിംബ് എലിവേറ്റ് ചെയ്യണം. ഏറ്റവും ഫാസ്റ്റ് അല്ലെങ്കിൽ ഇത് മെറ്റബോളിസം ഇത് പോകും. അതാണ് അഡിനോസിൻ. യു ക്യാൻ ട്രൈ ഇൻ ദിസ് പേഷ്യന്റ്. മോസ്റ്റ് ഓഫ് ദ ടൈം മോസ്റ്റ് ഓഫ് ദ പേഷ്യന്റ് വിൽ റിവേർട്ട് ബാക്ക് ടു നോർമൽ ആഫ്റ്റർ അഡിനോസിൻ. Then the ventricular tachycardia. So medical emergency, the focus in the ventricular muscle depolarization with a very high frequency, excitation spread by an abnormal path through the ventricular muscle. Here also you can't see a P wave, and the QRS complex wide and abnormal shape, and the regular QRS complex, and there is no identifiable T wave. So this is a classical ventricular tachycardia. T wave with absent P wave. That's simple ventricular tachycardia. But we have 4 conditions we consider. 1 sinus tachycardia, 2 atrial fibrillation, 3 supraventricular tachycardia, 4 ventricular tachycardia. This is ECG wise differentiate. In sinus tachycardia, we know there will be P wave, there will be tachycardia. 4 conditions tachycardia. But in sinus tachycardia, there will be P wave followed by a normal QRS complex. In atrial fibrillation, there will be absent P wave, no P wave, but varying RR interval. But in supraventricular tachycardia, there will be tachycardia, absent P wave, normal RR interval, but the QRS complex is narrowed. But in ventricular tachycardia, there will be tachycardia, P wave absent, and the QRS complex is wide, and RR interval is normal. This is the ventricular. That's why we differentiate between atrial fibrillation, sinus tachycardia, ventricular, and the supraventricular tachycardia. This is another ECG of a ventricular tachycardia with a wide QRS complex tachycardia. This is again another ECG with a wide QRS complex tachycardia. There are different types of ventricular tachycardia. Ventricular tachycardia and mechanism reward and not going to the details of it. So this is sine wave pattern of ventricular tachycardia. Ventricular flutter എന്ന് പറയും. താഴെ കാണിച്ചിരിക്കുന്നത് ഒരു പോളിമോർഫിക്, അത് ഡിഫറെന്റ് മോർഫോളജി ഓഫ് ദ, നേരത്തെ നമ്മൾ കണ്ടത് സെയിം മോർഫോളജി ഓഫ് ദ ക്യൂആർഎസ് ആണ്. ഇവിടെ കണ്ടിരിക്കുന്നത് ഡിഫറെന്റ് മോർഫോളജി ഓഫ് ദ ക്യൂആർഎസ് കോംപ്ലക്സ് ആണ്. ടോർസാഡിപ്പോയിന്റിസ് ഓർ ദ പോളിമോർഫിക് പോളിമോർഫിക് വെൻട്രിക്കുലർ ടാക്കിക്കാർഡിയയുടെ ECG ആണ് താഴെ കാണിച്ചിരിക്കുന്നത്. മേലത്തെ സൈൻ വേവ് പാറ്റേൺ. ഓക്കെ, ഇതൊക്കെ നമ്മളെ കാഷ്വാലിറ്റിയിൽ CMOs ഒക്കെ പലപ്പോഴും കാണുന്ന സാധനങ്ങളാണ്. Then the ventricular fibrillation. Ventricular fibrillation is a catastrophic arrhythmia characterized by rapid, irregular, disorganized ventricular. So my question is, so suppose a patient is in asystole or ventricular fibrillation, clinically നമുക്ക് രണ്ട് സെയിം ആയിട്ട് കാണാൻ സാധിക്കുള്ളൂ. കാരണം പൾസും BP ഒന്നും ഉണ്ടാവില്ല, അസിസ്റ്റോളിയിലും ഉണ്ടാവില്ല, വെൻട്രിക്കുലർ ഫിബ്രിലേഷനിലും ഒന്നും ഉണ്ടാവില്ല. പക്ഷേ വെൻട്രിക്കുലർ ഫിബ്രിലേഷനിൽ നമുക്ക് ECG പാറ്റേൺ കാണാൻ സാധിക്കും. പക്ഷെ വെൻട്രിക്കുലർ അസിസ്റ്റോളിയിലോ ഒരു ഫ്ലാറ്റ് ലൈനേ ഉണ്ടാവുള്ളൂ. അപ്പോൾ ഒരു പേഷ്യന്റ് ബ്രോഡഡ് ആയി വന്ന് അല്ലെങ്കിൽ ഒരു ആബ്സെന്റ് പൾസ് ആയിട്ട് വന്നു കഴിഞ്ഞാൽ ഉടനെ നമ്മൾ ECG മോണിറ്റർ കണക്ട് ചെയ്യണം എന്നുള്ളതാണ് മെസ്സേജ് കൊണ്ട് ഉദ്ദേശിക്കുന്നത്. ഓക്കെ, സോ വാട്ട് ഹാപ്പൻ ഇൻ വെൻട്രിക്കുലർ ഫിബ്രിലേഷൻ? വെൻട്രിക്കുലർ മസിൽ ഫൈബേഴ്സ് കൺട്രാക്ട് ഇൻഡിപെൻഡന്റ്ലി. ദർ ഇസ് നോ QRS കോംപ്ലക്സ് ഐഡന്റിഫൈഡ്, വിൽ ബി ഡിസോർഗനൈസ്ഡ്. ഏകദേശം ഈ ഒരു ചിത്രത്തിലുള്ള പാറ്റേൺ പോലെ നമുക്ക് കാണാൻ സാധിക്കും. ദർ ഇസ് നോ ഒരു ഓർഗനൈസേഷൻ ഒന്നും ഉണ്ടാവില്ല. QRSഉം PQRSഉം എക്സ്ട്രീംലി റെഗുലർ റിതം ആയിരിക്കും. ദർ വിൽ ഫിബ്രിലേറ്ററി പാറ്റേൺ. ഇൻ ദിസ് ടൈം യു ക്യാൻ സേവ് ദ പേഷ്യന്റ് ബൈ sometimes you may be able to save the patient by giving defibrillation. Okay, that is the ventricular fibrillation. Then the most important part of this presentation, that is ECG manifestation of coronary artery disease. That is, we know we have different entities in the coronary artery disease, like unstable angina, then STEMI and STEMI, etc. So in acute coronary syndrome, when you get an ECG, you take send for a cardiac markers. If it is negative, that is unstable angina. But negative serial cardiac markers sometimes can occur lately as positive. Then the cardiac markers positive, that is myocardial infarction, can be of two types: ST elevation MI or non-ST elevation MI, STEMI and NSTEMI. Okay. So markers changes in the blood, we have cardiac troponin, CKMB, and myoglobin. Usually we do cardiac troponin. It is detectable in 3 to 4 hours. Peak value occur in 48 hours. Duration can be up to 10 days. Okay. So if it is positive, that is considered as a myocardial infarctions. So we have to know about the coronary artery supply. That is the heart supply. That is with coronary artery. We have left coronary artery, and the left coronary artery divided into left anterior descending artery and the left circumflex artery. That supply the most part of the heart. Then the right coronary artery that mainly supplies the lateral posterior inferior part of the heart. Okay. Then according to the partial or complete occlusion of the coronary vessels, there will be various manifestations of the ECG changes can occur. Then the ECG changes of the myocardium can occur in the form of sometimes ST elevation or ST depression. ST elevation or depression if there is myocardial injury. T-wave, if there is inversion, T-wave like peaked T-wave or inverted T-wave or flattened T-wave can occur. Then there will be appearance of the pathological Q waves. If they are already necrostic, you can see the ECG. You can see in the ECG the development of the Q waves. So these are the different manifest various ECG changes of the ischemia or infarction. So ECG evolution in MI, again acute MI, within hours, the T-wave become peaked. There will be hyperacute phase, hyperacute T-wave will occur, then followed by ST segment begin to rise, followed by the progression of the ST segment and ST elevation occur. And within 24 hours, ST elevation begin to resolve, and loss of R wave
Jameel, hello.
സൗണ്ട് പോയല്ലോ.
സൗണ്ടും വീഡിയോ എല്ലാം പോയിട്ടുണ്ട്. എന്താണ് പെട്ടെന്ന് പ്രശ്നം?
സലീമ ഡോക്ടർ ഒന്ന് വിളിച്ചു നോക്കൂ.
നെറ്റിന്റെ ഇഷ്യൂ ആണ് സാർ. ഇപ്പൊ വീണ്ടും ജോയിൻ ചെയ്യും.
ഒരു ടെക്നിക്കൽ പ്രശ്നമാണ്. ഇപ്പൊ റെഡി ആവും. വെയിറ്റ് ചെയ്യണേ പ്ലീസ്. ലാപ്ടോപ്പിന് ഒരു ചെറിയ പ്രശ്നം പറ്റിയതാണ്. അത് ശരിയാക്കിക്കൊണ്ടിരിക്കുന്നു. ഒരു 5 മിനിറ്റിനുള്ളിൽ റെഡിയാവും. ഒന്ന് വെയിറ്റ് ചെയ്യണേ.
ഓക്കെ, നേരത്തെ പോലെ അല്ല ഇത് വരാത്ത. ചെയ്ത പോലെ
ഇപ്പൊ സ്ക്രീൻ കാണാം ജമീൽ സാറേ, ഓഡിയബിൾ ആണ്.
ഇല്ല.
സാറേ മൂവ് ചെയ്യുന്നുണ്ട്, സ്ലൈഡ് മൂവ് ചെയ്യുന്നുണ്ട്. സാറേ 89th സ്ലൈഡിലാണ് നമ്മൾ നിർത്തിയത്.
So ECG changes, we have seen the ECG changes in the acute evaluation of MI. Then elevation of the ST segment greater than 1, that is greater than 1 SMOX in 2 leads is consistent with a myocardial infarction. Here, നമ്മൾ നേരത്തെ സൂചിപ്പിച്ചതുപോലെ തുടക്കത്തിൽ ECG ക്ലാസിന്റെ ഏറ്റവും തുടക്കത്തിൽ നമ്മൾ സൂചിപ്പിച്ചിരുന്നു, each wall of the heart represents in different leads in the ECG. So lead 1 and AVL is lateral wall of the ECG, and lead 2, 3 AVF is inferior wall. Then the lead 1 anterior wall, lead 1 and 2 anterior wall, V3 and V4 septal, and V1, V2, V3, V4 നമ്മൾ anteroseptal or anterior wall എന്ന് പറയും, and V5, V6 is the lateral wall. Suppose if there is a lesion in the changes in the V1 to V6, we used to call as anterolateral or extensive anterior wall. So once again, 2-3 AVF inferior wall, 1 AVF lateral wall, V5, V6 also lateral wall, V1 to V4 anterior wall, V1 to V6 anterolateral or extensive anterior wall. So what is an anterior wall MI? So if there is an infarction of the left anterior descending artery, there will be changes in the V1, V2, V3, and V4. So anterior wall, you can see the changes of the anterior wall MI. In lateral wall MI, you can see changes in the 1 AVL and V5, V6 lateral infarction with ST elevation, usually by the left circumflex artery, rarely by itself. Usually it is associated with infralateral or anterolateral. Then inferior wall MI, you can see the changes in 2, 3, and AVF. There is inferior infarcted ST elevation, usually by the right coronary artery, and also the inferior wall is also supplied by the left coronary artery. ECG pattern വെച്ചിട്ട് നമുക്കത് ഏത് ആർട്ടറിയാണ് ഇൻവോൾവ്മെന്റ് നമുക്ക് അറിയാൻ സാധിക്കും. If there is involvement of the right coronary artery, sometimes associated with the first degree heart block, second degree heart block, or third degree heart block, because we know the conducting system like SI node and AV node is supplied by the right coronary artery. So right coronary artery can right coronary artery block can lead to the inferior wall MI along with the heart block. Then the posterior wall MI. Actually, the posterior wall of the heart is not represented in any ECG lead. Suppose if there is a posterior wall MI, we will get a mirror image of the ST elevation in lead V1 and V2. Then rarely we may get RVMI, that is the right ventricular myocardial infarction. Right ventricular myocardial infarction, classical triad is the hypotension, jugular vein distension, and the right lung feeds, right lung sounds. Suppose number inferior wall MI with the hypotension and jugular vein distension, ECG you take a special lead also, that is V3R and V4R. ST elevation. So that is called RVMI, right ventricular myocardial infarction. In that case, you have to give the fluid resuscitation. Classically clinical picture are hypotension, jugular vein distension, and the dry lung sounds. That is right ventricular myocardial infarction. Ini namakku കുറച്ച് ECG കാണുകയാണ്. ECGയോട് കൂടി ഇന്നത്തെ ECG ഡെമോൺസ്ട്രേഷൻ ആണ്. ECGയുടെ കുറച്ച് സ്ലൈഡുകൾ മാത്രമാണ് കാണുന്നത്. അതോടുകൂടി ECG ടോപ്പിക് നമുക്ക് അവസാനിപ്പിക്കാം. കുറച്ച് ഇന്റർഫിയറൻസ് വന്നു. Anyway, we will finish it within the short time. So what is this ECG? You can see the ECG. എല്ലാവരും നോക്കുക. You can see an ST elevation in the V1, V2, and V3. V1 അത്ര വന്നു തുടങ്ങിയിട്ടില്ല. V2 and V3. So there is an evolving MI with a Q pattern in V2 and V3. But we resolve XT elevation resolve with a T inversion. So V1, V2, V3. There's a QMI, that is QS pattern. You can see the V1, V2, and V3. This is called the anterior wall MI with evolved pattern, evolved MI with the appearance of the Q V1, V2, and V3. Okay. So in lateral wall MI, you can see the ST elevation in the lateral leads, that is the 1 AVL. ST elevation in the lateral leads, and V5, V6, that is the lateral wall MI. Okay. And inferior wall MI. So what is this diagnosis? Inferior wall MI. You can see ST elevation in 2 leads, 3, and AVF leads. That is a classical inferior wall MI. Okay. Inferior wall MI. Before that, what is this? Here you can see a QS pattern in the evolving anterior wall MI with an ST elevation without Q4 formation in the lateral leads V5 and V6. Okay, so anterior wall evolved MIUI, V5, V6 lateral wall MIUI. Okay, this is an anterolateral MI, developing MI. Anterior wall the lateral wall extend your ECG pattern with some reciprocal changes. Reciprocal changes, exact mechanism not known. Suppose if you are seeing reciprocal changes that indicates extent of the infarction, severe infarction. Reciprocal changes means there will be ST depression in the other leads. That is, if you are seeing an infarction in the ST elevation in the anterior leads, you will get ST depression in the inferior leads. If you are getting an ST elevation in the inferior wall, you will get the ST depression in the anterior leads. That is called reciprocal. Reciprocal changes indicate extended infarction. Okay, reciprocal changes. Here again, there is an inferior wall MI. This is an inferior wall MI 2-3 AVF. Then I have mentioned inferior wall MI. You can have different pattern. That is the can be due to right circumflex artery, left circumflex artery occlusion or right coronary artery occlusion. ECG നമുക്ക് എങ്ങനെ characterize ചെയ്യാൻ പറ്റും? Suppose if the ST elevation of the second lead is more than the ST elevation of the third lead, that indicates the block is due to, CAD is due to left circumflex artery. Suppose if the ST elevation is of lead 3 is more than lead 2, that is the right coronary artery. So that is helpful in localizing the artery in inferior valve MI. Here again you can see an inferior valve MI, possibly ST elevation lead 3 is more than lead 2, possibly right coronary artery. Along with you can see the posterior valve MI mirror images in the V1 and V2. Okay. This is not MI, this is a classical monomorphic ventricular tachycardia, ECG of a ventricular tachycardia. This is a polymorphic ECG of a polymorphic tachycardia. Dorsal point is, oh, this is the this is the wardenal patient recently I took. This is inferior valve MI, V1, V2, there is a changes in the lead 2, lead 3 and AVF, inferior valve MI. This I got the ECG 1 week back in my last duty day. I got a call from the surgery ward, a patient with the diabetes, admitted in diabetic food, suddenly developed pulmonary edema, severe dyspnea and severe desaturation. It was pulmonary edema and ECG showed extensive ST depression in many leads. That was NSTEMI, cardiac enzyme raised. So that was the reason for his pulmonary edema, acute MI with the form of NSTEMI, ST depression in many leads. That is the NSTEMI pattern of the myocardial infarction. Here you can see an inferior valve MI. This also from my ward, from our ward. That is inferior valve MI. That is 2-3 AVF. Inferior valve changes. You can see the next ECG, almost back to normal after successful reperfusion with streptokinase. Almost the case. So there's a regression of the ST elevation occurred in the second ECG after a few hours. So this is indicative of successful reperfusion with the SK. Okay. Then ECG changes can occur with some electrolyte abnormalities. I'm not going to details of it. You can get the ECG abnormalities in hypokalemia, hyperkalemia, hypocalcemia, even hypomagnesemia and hypermagnesemia. Hypokalemia usually produces ST depression and flat T wave or U wave. Hyperkalemia, prolonged PR interval, QRS widening or flat P wave or tall peaked T wave, classical hyperkalemia. There are so many manifestations that can occur with various electrolyte disturbances. This is an entity called a Prince metal angina. It's the mimicker of MI. Actually, it is not an MI. You can see an ST elevation in the leads, classical of MI, but that ST elevation completely resolved when the pain relieved. This is called a Prince metal angina or vasospastic angina. Rarely, we can see the complete pain, complete ECG normal. This is actually not MI. There is no occlusion of the vessels. It's called Prince metal angina or vasospastic angina. Okay. Then the pulmonary embolism can also be diagnosed by ECG. There are different manifestations by ECG manifestation pulmonary embolism, sinus tachycardia in 8 to 70%. Sometimes you may get P pulmonary. The classical pattern is S1, QT3, and T3. That is S1 in lead 1 and Q in lead 3 and T inversion in the lead 3 pattern. That is called S1, Q3 and T3 inversion. So one more slide. With that, I'll conclude my session. So that is the Brugada syndrome. So what is this? Hereditary syndrome marked by a right bundle branch block with ST second elevation in the right precordial leads and a high risk of sudden death can occur with ventricular arrhythmias. The congenital heart syndrome causing sudden death. One of the examples is a Brugada syndrome with ST elevation and the right bundle branch block. Here the treatment is cardioversion. As I was shown in this figure, you can see the defibrillator is implanted. That is implantable cardiac defibrillator. It delivers the shock at the time of arrhythmia occur. So that is a treatment of choice for Brugada syndrome. Okay, and okay, this is the last slide. What is this thing? You can see an ST elevation with convex convert elevation. This is J point elevation. This is normal. Actually, this is not an MI. ഇത് പലപ്പോഴും നമുക്ക് റെഫറൻസും കൺസൾട്ടേഷൻ കിട്ടുന്ന ഒരു കണ്ടീഷനാണ്. യൂഷ്വലി ക്യാൻ സീ ദ നോർമൽ യങ് പേഷ്യൻസ് വിത്ത് സം young patients who come with some other reasons. ECG pattern like this is called J-point elevation or concave upward elevation. The concave elevation of the ST segment. This is not an MI. പക്ഷെ എങ്ങനെ ഒരു ECG കിട്ടിക്കഴിഞ്ഞാൽ നമ്മൾ യഥാർത്ഥത്തിൽ പേഷ്യന്റിനെ വിടരുത്. You take the repeat ECG. If it is the repeat ECG again shows the same thing, you can send the patient home back. But നമ്മൾ follow up വെക്കേണ്ട ആവശ്യമുണ്ട്. This is called the J-point elevation. Okay. So with that, I conclude the topic. Thank you.
ഓക്കെ ഡോക്ടർ ജമീൽ, ഏതായാലും നമ്മൾ ഈ ഹെൽത്ത് ഫോർ ആൾ ഈ ലോകാരോഗ്യ ദിനത്തില് നമുക്ക് ഏറ്റവും മികച്ച ഒരു ടോപ്പിക്കാണ് ഇന്ന് കോഴിക്കോട് KGMOA അറേഞ്ച് ചെയ്തിട്ടുള്ളത്. അതിൽ നമുക്കറിയാം ഈ എല്ലാ ഡോക്ടർമാർക്കും അറിഞ്ഞിരിക്കേണ്ട കാര്യങ്ങൾ വളരെ ലളിതമായും അതേസമയം അത് വളരെ ഫലപ്രദമായ രീതിയിലും ആണ് ഡോക്ടർ ജമീൽ ഷജീർ അവതരിപ്പിച്ചത്. എക്സലന്റ് സെഷൻ. ഡോക്ടർ ജമീൽ പ്രത്യേകം നന്ദി പറയാണ് KGMOA അക്കാദമിക് സെല്ലിന്റെ. ഇത്രയും വളരെ നല്ലൊരു ക്ലാസ് ആയിരുന്നു. ഏകദേശം 172ഓളം ആൾക്കാർ പങ്കെടുത്തിട്ടുണ്ടായിരുന്നു. എല്ലാവർക്കും അത് വളരെ യൂസ്ഫുൾ ആയി. തീർച്ചയായും ഇത്രയും നല്ലൊരു ക്ലാസ് KGMOA